All right, welcome, friends, colleagues, students, citizens of the world. It's your boy LeRoy Horton back with another episode of the Teach Me Implants podcast. And we're back, baby. The
Yeah,
dynamic duo has returned today. I got my good friend, Dr. Walter Ackah from the Tooth Be Told podcast.
that's
How's it
right.
going, brother?
Oh man, real good, brother. Hey, look, I was just saying how unusual this is. I've taken a hiatus, and then here you are being so gracious enough to bring me onto your podcast. And so I'm sitting here trying to reorganize myself, put the studio back together.
Well,
This is
let's be
not the
real with the audience. I kind of strong armed you, stole you away from your kids on
no.
Thanksgiving morning. The kids were like, "Dad, I want to play soccer," and you were like, "No, I got to do this podcast.
No,
Sorry."
no, don't do that. Don't do no, not even close. No. This is a good break. This is a good break. And it's funny because we had everything organized and then I'm sitting here and I actually if it wasn't for my daughter, I would have actually forgotten that we were supposed to be doing this. She was like, "Didn't you say something about a podcast?" I was like, "Oh man, hold on." So no, for sure. This is something that's I'm excited about. I'm really excited about. The topic is not that exciting, but I'm excited to just be back on the podcast with you, my man. Because it's been you've been missed. You've been missed. You know what I mean?
I have missed you
But
too, brother.
but it's
Yeah.
funny. I watch every episode and I give you a hard time. I'm like, where's your next episode coming on? What's going on with you? What are you doing, right? And now I understand how it is. Like because people used to contact me. Hey, when are you putting the next one up? Don't
Right,
ever
right.
skip like a week or two, and all of a sudden
No,
everybody thinks that that's all you do is podcasting. So
right, right. No, I think what's amazing is a lot of people assume that there's like money in this, and I'm like, money? There, like, there's
you can do
money in
that.
that? You can do that?
No, I agree. And people, I mean, I don't know if people realize that a lot of stuff is self-funded. I know
Hmm.
that's how it is with you and that's how it was with me. And it was basically we would always just be like, "Hey, we're just doing this because we want to educate, we want to talk to people. We want people to understand what it looks like." Right? Not this is not for oh, I want to sponsor this or I want somebody to buy this from me or whatever. Like most, you do that on your own. I mean, you lecture everywhere internationally, so you don't have to worry about that at all. This is you doing extra unnecessarily. To be honest, you should have you should have taken a break when I took a break.
No, I do this because my wife don't want to listen to me anymore. So I'm
There it
sitting here
is.
like I need to talk. My mouth needs to move, and she's
There it
like,
is.
"I can't take any more of these stories. Call your friend Walt. Talk to him." So I'm like, "Okay."
Why does that sound so familiar? She doesn't know what to do with me when now that I'm done. You know what I mean? But anyway, man, honestly, I'm so glad to be back. I'm so glad to be back on your show. I'm actually glad to be back to be on your show because of how much of a fan I am. If
Oh,
you ever
thank you.
see me, if you see comments, it's just usually me. Just be like, I would do this or I would do that. So I need a life. That's what it comes down to. I need a life.
Well, let's dive into some topics, man. We got two topics I wanted to pick your brain on today. One of them a little bit more somber than the other. Very relevant in these times of dentists trying to do everything.
Mm.
Okay, so I want to open up with I'm going to screen share here.
While you're putting that up, I just want to say that a lot of what we're about to talk about happened in my hometown of Houston.
Hmm. Yes.
Right? This is not something to be joyous about. This happened in my hometown of Houston, and it happened to, somebody that I know.
Hmm.
And it also happened to, what I'm going to say is the clinician, something like this happening is not something that is unusual, unfortunately, happens, right? And it happens in medicine with MDs. But when it
Hmm.
happens in dental with DMDs, man, it's just like I knew it. This should not be They should not be doing this. This should not be doing that. So I feel like dentists, we are held to a way higher standard,
Hmm.
and I feel and I feel like it's one of those things where let something go wrong, you'll hear so many people. I'm talking about this was in the news. I mean, everywhere. You had other dentists, other we'll call them influencers talking about this,
Hmm.
but
Yeah.
we never really talk about the joyous things that happen in dentistry. But let something like this happen,
Hmm.
man, right? I
And
mean, think about that.
but one of the things the good part about talking about it is that you have to bring awareness because every generation has this new crop of cowboys and cowgirls who
There you go.
are doing too much. And I think me and you have talked about in the corporate takeover of dentistry, providers are pushed to produce at all means. And so this particular case, I'll play for you here. So it's a man in his 40s that died during sedation from an oral surgeon. I wanted to look at what are some of the things that are said. Mind you, we don't have all the information, but we do know that there was a lot of concomitant systemic conditions, high blood pressure, diabetes, and so forth.
Obesity, that's a huge one.
Obesity, yeah. And the medications that were given were Versed, otherwise known as midazolam, propofol, ketamine, and they listed here ketorolac as anesthetic, but we know that's anti-inflammatory.
But do you see
So,
anything out of the norm?
well, I'll be real with you. What I
Please.
do see, let me
I'm
enlarge my
guessing you're gonna
screen
say the
here.
propofol, right? Yeah.
Well, for an oral surgeon, that's not out of the norms,
Right.
right?
Right, and that's where I was going with that, yeah.
I guess my concern is if we're talking about what's being done in a dental office,
Mhm.
there's a couple things that you have to make sure. You need to make sure that your dental office is equipped to handle sedation, right? Number one, do you have all your emergency drugs, emergency oxygens? Do you have your advanced airways, your LMAs, and all that, depending on the level of sedation that you're doing? Do you have adequate training? Do your staff have adequate training?
That's the key.
Have you trained emergency protocols? I don't know how it is down in Texas, but here in Washington, they did change the law saying that you had to do emergency drills every 6 months in your
Yep,
office,
yep,
which
yep.
I think is amazing. And we'll dive deeper into that as we get into this conversation. And then, second of all,
You got me about to trip out because no one does this.
no
Not that
one.
I've seen.
Right, right. And so let me ask you this. So if you're trained as a periodontist to do IV sedation, okay? So you did your minimum 60 didactic hours. You did your, depending on the state, 17 to 21 supervised cases where you're doing the sedation. Depending on the state, when you try to get your license, your facility might get inspected, or at least the state reserves the right to inspect the
Inspect.
facility. You have to get, 8 hours of continuing education in sedation per year, and so forth. But you made the conscious choice at some point that you weren't really comfortable doing the sedation and the surgery in the settings you were at. Because even though you were doing it safely, you were like, "Is it really worth the risk?" Tell me,
Come
tell
on,
me
bro.
about that. Tell me about that evolution.
No, so it basically started off, right, just like you said, when you get out, you wanna do a lot. But as time goes on, you realize, "Is this worth it? Is this beneficial to me? Is this something that makes me comfortable?" Right? Because the facility, because don't forget I travel. So the facilities aren't always necessarily up to date with or up to code with certain things, medication, like you said, supply, airways, supply. They may not have all that. And then on top of that, assistants, are they properly trained?
Hmm.
Because you're not really training them. You're dependent on, hey, is this done? Do you have the right stuff? Are you keeping up with your CEs? All those things. So you get to a point where you just go, this is just not worth my license. This is not worth the headache. And that's really what it was. If I was stationary, if I was in an office and I knew that I was more in charge of this assistance training, the supplies, the medications and all that, right? Because remember, there's some medication people don't check medication to make sure they're not expired, right? Think about it. Like if you have an EpiPen once a year, it's one, and then after a year, you have to dispose of it. People don't think about that. They go, I just spent $60 or however much you get, depending on where you get it from, and you're telling me that I didn't use it and I have to throw this away after a year. People may not want to do that, right? And so these are all factors that led me personally, I'm not going to speak for anybody else, to say this is just not worth it. Now, financially, do people take a hit? Yes, because sometimes if you're doing an extraction, for example, it may be more beneficial for you to sedate that patient because financially that's more, right? That you're stacking more on, right? Second, patients love to not remember dental treatments. And I don't blame them, right? And so there's maybe we'll say, what do you say, 20 to 30% of patients that you've eliminated by not sedating. I mean,
Hmm.
what do you think? That
I got
around that?
roughly, yeah.
Right. So you've eliminated your pool, right? And then on top of the third The third avenue is basically for your own sanity, because there are some patients you want to sedate. There are times where I'm like, I need you to be asleep. I cannot deal with you right now because you're way too hyped up, right? This is taking way longer than it needs to. So, from a personal, selfish point of view, I want to sedate most of my patients, right? But again, it all came down to, is this something that I feel comfortable with? Is this something that I want to deal with? The consequences? Do I have the adequate stuff? And it just got to the point where, after a while, you're not chasing the money. So you go, this is just not worth it for me. I want to sleep well. I want my patients to know that I'm giving you to the right person. But don't get me wrong, there are some cases that I will actually call on a good friend of mine who is a dental anesthesiologist to come and sedate my patients. I'll do that easily, every day, all day.
Right. So
Hmm.
in this particular story, we've got a couple knowns that we have. We don't know the whole story, so I'm not we're not casting any aspersions or judging guilt. But we've got a patient that was overweight,
Hmm.
high blood pressure, diabetes. We know from as being providers that provide some level of sedation that's deeper than just a one-time oral sedative or nitrous oxide. With moderate sedation, and I did my training with Amanda Okunde, who's an amazing dental anesthesiologist out of Vegas, Stanley Malamed, Ken Reed, and all them. And one of the things that they taught us was, if this is kind of the level, this zero, and this is about as risky as you could be as a non-anesthesiologist, we're going to set the bar of safety here. Meaning, you
So out
could
of 10,
technically,
give us
you
out of
could,
10.
so out of 10, if, anything say above a 5, you should probably get a dental anesthesiologist. We're going to keep your safety at like a 2.5. And I love that because I've probably done over 400 cases of sedation while I'm doing the surgery, and a number of cases while I'm doing the sedation from someone else. And there's risk factors. I go through health history. I'll get consultations from medical doctors. I assess the airway. We have a BMI cutoff above a 35. We're just not doing it, right? So, in your expertise, in your training, when it comes to something like weight, remember, this isn't judging the patient. This is judging the provider's decision making. What comes with someone being slightly larger that can potentially cause some difficulties during the sedation?
Bro, the first thing, I mean, the only thing that you should really be focusing on is airway. If you're overweight, you lay back, you've now collapsed the airway. You've made it smaller than it already is. You have fat. You have no offense. I mean, I feel like every time I say something nowadays, I'm offending somebody. But you have fat. You have with airway. Don't forget, it's not just through the mouth, nasal, right?
Mhm,
They may have other issues associated with lack of, maybe, I don't know, sinus closures. You may have polyps. There's so many factors that are already going against you. You don't want the obesity or BMI to be another factor that goes against you, which causes lack of airway. And that's what you're really focusing on. And I can guarantee you, it wasn't the diabetes unless it was uncontrolled. It wasn't the medication. It was the airway that probably led to a lot of this problem,
right,
right? And
right,
and and that's the biggest thing for me is, when we talk about airway, we're really focusing on a few things. If a patient has, let's just say, sinus infection, right then and there, I'm not doing this. Hey, let's reschedule. Patient is obese. Let's reschedule. We check airway. We check tonsillar sizes.
mhm,
You check tonsils. If your tonsils are touching, and it's funny, my daughter has really large tonsils, and she's not overweight. She's not obese.
mhm,
She just has really large tonsils. And so when you look back there, and you can even go to the mirror. Anybody that's listening that's not dental, go to the mirror, open up, say, look back there, and if you see those two little dangling, not dangling on the side of your back of your throat, and they're touching, that's
mhm.
another avenue of constriction for airway. We check all those things. That's what you should check.
Should. Should, yes, and we call that a Mallampati score. Essentially is a score of how open and accessible your airway is.
And
Um
can I add, in Houston, or air quality is really not the greatest. It's pretty bad, right?
mhm,
So a lot of people have allergies that
mm,
also inflame back there, which then causes constriction of airway, causes mouth breathers and so forth. And so yeah, that's another, so time of the year, that's another factor.
yeah. Yeah, airway quality, time of the year, allergies. And when we talk about airway constriction, especially in overweight patients, it's even more so in patients that tend to have a lot of fat in and around their neck.
You say you're not offending anybody.
No, no, no offense. No, for sure. But it's one of those things where, okay, so we talked about our airway, but there was more to this story, just like there's more to every patient that we see. There was some level of heart disease, hypertension combined with metabolic syndrome that was probably contributing to atherosclerotic disease. If you get a patient where, let's say they make the BMI cutoff for you and they got a Mallampati 1 or 2, so you feel like, okay, but they have listed some type of heart condition.
Mm.
What would you do if you were unsure about the ramifications or the severity of that particular heart condition? What would be the prudent thing for you to do?
And unless you're trying to trick me, you get a medical clearance. Unless you're trying to trick me,
Right.
you get a basic medical clearance. If anything, you put that patient through their cardiologist stress test, something that says that, hey, this person can sustain or go through what you're about to put the patient through.
Right. No, that wasn't a trick question. But the reason it sounds like a trick question is I come across so many providers that do not do medical consults. For example, if I'm especially going to do something like sedation or just even a large surgery where we're going to give a ton of anesthetic, so we're going to be pumping them full of epinephrine and causing stress because it's a stressful procedure. If I see that they're on blood pressure medication and maybe they make the cutoff, right? Maybe they're like 145 over 95. So they're under that 160 over 100, which is the general dental cutoff. But they're on 3 different blood pressure medications, right? They might be on a diuretic, a calcium channel blocker, on a ARB or whatever. To me, that is a red flag. Like, wait, so you are taking 3 different medications and you're still just under the cutoff. What are some of the ways you assess health history to make a decision to do or not do or to reach out to the PCP and get a consultation?
Well, let's start off by saying that, and patients say this a lot. They'll say, well, this environment is causing my blood pressure to go up. And I'll tell them the same thing. I said, I get it. And then, like you said, you have medication that should be bringing those numbers down, and it's not. So right now, we're not controlled.
Mm.
And that's something that a lot of providers kind of say, okay, the patient said that they're on medication and they didn't take it today. Not taking it one time shouldn't
Right.
spike your systolic and diastolic that high. Right. And that's something that I hear consistently. Or I'll see medical history where they have consistent high blood pressure.
Mm-hmm.
And I'm like, this is not a one and done situation. This is a consistent situation. You were here 3 months ago. You were here 6 months ago, and your blood pressure was still high. To me, that's what really indicates whether or not I'm getting a clearance from a cardiologist. Right. And then on top of that, family history.
Mm.
Family history plays a proponent on that. Right. We'll speak for my culture. We'll speak for the Ghanaians, right, out there and the Africans out there. Our food is very rich and also has a lot of sodium. Right.
Mm-hmm.
And so we look at that and we say, okay, what could be causing it? Maybe our diet. If you look at the Indian culture, you have a lot of high cholesterol. So that's another thing. So we have to look at culture and we have to look at food and everything that's associated with that. I know that's, I sound like a hippie maybe, but these are all factors that goes into whether or not we need to go ahead and look, right? Are we more prone based on diet? Are we more prone based on weight? Are we more prone based on family history? Are we more prone based on medications that you're taking, health history? All these factors lead me to say we need to just get a medical consult. And there's nothing wrong with doing that. And one of my mentors told me this a long time ago. You're not getting a medical clearance for permission. You're getting a medical clearance for your edification because most of these doctors don't even know what you're doing.
Right. Right.
Tell me
right.
if I'm wrong. You've worked with enough and you got enough medical clearance that they don't even know what you're writing about.
They don't. They don't. And you're right. And so my key takeaway from what you just said is that you should at all costs avoid Ghanaian jollof rice.
But don't say
because
that
it's
now.
bad for your health. That's
This
what I
is why I
heard.
didn't want to come on the
I
show.
heard jollof rice from Ghana has too much sodium. We care about the black population, so avoid Ghanaian jollof rice.
This is why I didn't want to come on the show. You see, I don't know what's happened to you in the few months since we've been separated, but there's some kind of Nigerian influence. I'm sensing Nigerian influence in this, but I'm going to forgive you and we're going to stay focused because, this was a very, very professional discussion until you brought that ridiculousness
Well,
into the
well,
equation.
my ancestry.com did put me at like 21% Nigerian
Ugh.
ancestry. And so I have to at some point acknowledge that maybe there is a difference between, because I've never heard a Nigerian say that their jollof rice can kill you. But I feel like you just said that about
So, one, I didn't say
Ghanaian,
that.
right?
One, I didn't say that. Two, they're not honest. I didn't want to say anything, but they're not honest. They're not honest people. How many times have you heard of Nigerian princes robbing people from their life savings? Have you ever heard of Ghanaian princes robbing anybody from their life? You've never heard this. You don't hear scammers talking about Ghanaian
You got a
princes.
point there. I've
Thank
never
you. I
heard of
didn't
a
want. Thank
Ghanaian
you.
scammer yet.
Listen,
Right?
I love my Nigerian brothers and sisters, but sometimes you guys do some shady stuff and you say so, and then you have this 21%er coming through talking ridiculous. And you see, you got me riled up right now. I apologize
Right.
to the listeners. I'm sorry. Let's get back to professionalism.
Let's get back to it. But I like what you said. I think evaluating health history, getting that information from the PCP, the patients are often really bad reporters of their health history. Doctors, dentists, are often bad investigators of
Mm,
health history. The amount of times, and you've probably seen this as a traveling doc, that I've walked into an office to do a consultation and I'll see a bunch of yeses marked on the health history and there's no notes. I'm like, wait a minute. You marked yes on heart problems, you marked yes on thyroid, yes on this. Like, so I go through it all over again, and you'll see my scratching notes of, what type of heart medications they're on. Is there any history of myocardial infarction? Any history of surgery? What was the most recent A1C if they're diabetic? I carry a glucometer with me. I do a blood glucose check.
nice.
A lot of patients now, it's so convenient. They'll have their My Chart or their Kaiser chart on their phone.
Yes.
They can pull it up right up for you, and I insist on it.
Yes.
And I don't know if that's just the specialist training in me now. I feel like I did that before as a
Right.
GP to a certain extent,
Right.
but it's alarming how many dentists are not
Right.
doing that.
And don't forget the continuous glucose monitors, like you said.
Hmm.
That's been key because even people who are not overweight, who don't have diabetes, are monitoring their glucose all of a sudden, right? And so there's really no excuse. And like you said, the My Chart, there's no excuse to not get the right information. And here's the funny thing: I'm not sure if you've noticed this too, but patients will just mark no sometimes for everything just to get through the health history part of like the digital, because especially older patients will basically just no, 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 just go through it. And then when they come to you, all of a sudden they're telling you all these medical issues that they have, and you're like,
Hmm.
but it doesn't say that on
But
the chart.
no,
I just wanted to get through this so much. They had me answering so many questions. I was
right.
like, for
You
for
don't need to know that. This is,
right.
you're
And
just
then
a
all of a
dentist. You
sudden
don't
they
need to
go,
know.
and it looks like a CVS receipt. You just roll it
Right,
out, it just comes through, and you're like,
right,
that's your health history? Oh, yeah, yeah. But why didn't you mark it on here? Oh, it was a lot. I didn't know how to even
right.
use that computer. I was like, okay.
So we've done airway,
Mhm.
we've talked airway, we've talked systemic conditions, which obviously we could talk for days on all this stuff. So we're trying to condense it for the listener. The other thing I wanted to talk about is when we look at the cocktail of drugs that were used. When you did your moderate sedation training, and again, to separate for any listeners, the level of sedation that oral surgeon does is usually deeper and obviously I think aptly called deep sedation. And the level of anesthesia that an anesthesiologist would do would be general sedation. Propofol is typically used, propofol and ketamine in what we call deep sedation.
Yep.
But either way, we learned in moderate sedation certain protocols to ensure safety in your mode of delivery. Now, can you talk to us a little bit about titrating to affect your dosages, and what would that look like when you're administering a drug during moderate sedation?
Well, so I mean, don't forget weight also plays a factor, like you'd mentioned earlier, right? So when you titrate, you start small, you start very minimal amount, right? You basically try to see what is going to get that patient just on that cusp of relaxation. On that cusp of relaxation, but the key is they're still able to breathe on their own without any kind of without any kind of limitations to their breathing, right? And I want to kind of go back a little bit and understand general sedation usually is intubated, meaning
Mhm.
that there's a machine or something breathing for the patient. versus mild sedation, moderate sedation, where the patient is able to breathe on their own. And I think understanding that is going to be key to understanding this whole discussion, right? And another thing too is don't forget anything that suppresses or lessens the patient's ability to breathe is not what you want in mild, moderate, or sedation. You don't want that at all. And so what you said was correct, right? The propofol, remember Michael Jackson, my hero at one point, was my musical hero. Let me just rephrase that, please.
Yeah, we're
Musical,
not going to get into some of the other
musical,
controversies of Michael
musical hero,
Jackson. We'll keep
right?
it to the music.
Right. What happened? He died when his doctor basically was giving him propofol.
Mm-hmm.
Right. And we know, remember the milk, remember they talked about milk and all that stuff, right? That is something that, like you said, it's basically used for more deeper generalized sedation. And so again, it suppresses breathing, it suppresses not airway, but it suppresses breathing, right? The ability to just breathe on your own. And so that's something that you want to try to avoid. And like you said, I'm not sure why this provider used that unless they were trying to aim for a deeper sedation based on the patient's weight. Maybe it doesn't make sense, but again, we are not here to litigate anything. We don't, like you say, we don't know, right? We don't know. Yeah. Man, it just upsets me. It really does. It upsets me because I feel like there has to be other factors. Because this provider cannot be this naive. There has to be other factors. Speed must have been associated with this. Because, like you said, when you titrate, it takes a little bit of time. It takes longer for the patient to get to that level where you feel ready to go. But if you knock somebody out with propofol, you're getting started in 5 minutes.
Right.
So
Right.
that's something that I bet you was a factor. And again, I'm saying allegedly, I don't know, but I bet you that was a factor, was time, and maybe the provider's schedule was so packed that these were like, or maybe they were running behind.
Mm-hmm.
That's the only thing that can make sense to me, to not do what you said, which is titrate the patient, get them to a nice, comfortable level, and then go from there.
And I will piggyback that because you're right, and especially in the corporate world, and this is a corporate dental outfit, owned by private equity money. I think they said it was like Griffin Industries or
Oh, it doesn't
Griffin
even
Corp
matter
or something.
because they're going to
Yeah,
sell it to another private equity in 2 minutes
yeah.
anyway. So by the time you say their name, it's already been sold.
But these models are based on production. They're based on speed. And what I found, you're right, when you titrate, so for the layperson on here, titrating means you give a small dose, you see the effect. If you feel the need more, you give it a little bit more. And so we learned that ideally, to be as safe as possible, let's say with midazolam, right? They wanted us to give 1 milligram over 1 minute and see that. Now, that is very slow, but clearly, obviously, if you're treating or educating lower level providers like we were, right? We got anesthesiologists training lower level providers and us, you're going to create that safety margin
Of course.
as safe as possible, right? But it does take time.
Because
And
you can always pull back. And that was the key. I'm not sure what they told you, but you could always pull back. You didn't have too much on board where you couldn't pull back.
And the thing is, you never know how someone is going to react to either the sedatives or the narcotics. So I've had patients where big burly guy, and in my head, tattoos, I'm thinking it's going to take a lot to put him down. He was gone after 2 milligrams of midazolam,
Yep.
and not gone as in asleep because we're not putting him to sleep, but he was just so high out of his mind.
That's it.
We got all the work done literally off of 2. I've had other patients, young patients, very small, and we had to give upwards of 15 milligrams of midazolam to get them where we wanted them. And so you never really know. And the other part is, especially with your older patients, we always talk about halving the dose you would anticipate giving, because for a lot of them, with their metabolism having slowed down, their cytochrome P50 being, and that's the enzyme that breaks down a lot of these drugs, you might give them something and it lasts a lot longer than you'd want it to. And so now you're worried about them, in your chair, you can have certain ways to protect the airway. You lay them back, you make sure their chin is up, you're listening to their breathing. I have a precordial stethoscope that's Bluetooth, so I'm listening to their
Nice.
breathing the whole time.
Yes. Yes.
I'm checking, I got the wavelength capnography, so I see not only are they breathing, but are they metabolizing the oxygen and giving off an appropriate amount of carbon dioxide? But when you release them, if that drug is not metabolized at the expected half-life, they're going to get home and they're not going to be in a protective position to protect the airway. They might be, if anyone's looking at me, laying down like this, head goes down, nodding off. all of a sudden my airway is constricted,
That's it.
right?
That's
And that's where a lot of the adverse events post sedation come from, is from airway closure after the procedure is actually done.
Can I ask you a question? I wanted to kind of piggyback off two things for you. First off, you were talking about how you're able to monitor their breathing, right?
Mhm.
With a Bluetooth. If let's just say our listeners aren't fancy like you, right? They're not fancy. And so they don't have that Bluetooth. How many minutes in between do you monitor? Like, let's just say you're the one doing the procedure or somebody's helping you do the procedure. You're doing the procedure and somebody's monitoring. How many minutes would you say, hey, check the breathing before we continue?
Well, and I'll be full disclosure on my process. In the state of Washington, I'm assuming like other places, you have to have a dedicated assistant that's just monitoring the sedation. So I tell my patients, you're looking for, or my assistants, I want your eyes glued on the patient,
That's it.
and you're
Yeah,
watching for chest rise at all
that's it.
times.
That's it. That's I wanted to kind of get
Right.
you to yep. Yeah.
At all
Because
times.
some people may think, "Oh, every 5 minutes I'll stop and check their breathing," but that's too
Right.
late,
Yeah.
right? Because now you don't have oxidation to you don't have oxygen going to the brain, which again, remember, it can lead to brain death and so forth. And then the second thing I wanted to kind of discuss with you was you said, "Oh, okay, well, the patient had to." You said something that I want people to understand is we'll lift the patient's head back, right?
Mm-hmm.
And what you're doing is basically creating an airway, right? And one way to know if a patient doesn't have adequate airway, we always say adequate airway, is when they start to snore.
Mm-hmm.
So talk about that, right? Because I think that's important for people to know. And that even works when you're doing treatment on a patient that's not sedated and they're tired and they're right. This is how you know some of these patients would be difficult to sedate. Because if let's just say they're getting a filling done to the general
Mm-hmm.
dentist out there and you hear it snoring, what are you thinking? As somebody who does sedation, what are you thinking?
Well, my first thought is history of obstructive sleep apnea, constricted airway. And if they're falling asleep, and I literally, I know some people may have a hard time believing this. When you're doing this for a while, I've had patients where I'm talking to them, no sedation. I'm doing health history, we're just doing a consultation. And the moment I lay them back to take a look inside, they're snoring.
Yep.
And that, I mean, and that tells you that level. And with that particular patient that I'm referencing in my mind, I brought his wife in and I had a long conversation with her, with him there. And I said, listen, this is what we see, kind of went down the whole algorithm of his health history, obesity, hasn't been to the doctor in 15 years, asked, does he snore? Does he stop breathing? Yes, yes, yes. And I said, well, listen, I can tell my man here till I'm blue in the face, he needs to go see the doctor. But clearly, he's only
Mm,
motivated when something hurts him. I asked her, and that dead serious. I said, "Do you love your husband?" Of
mm.
course I do. Do you want him to die 10 or 15 years prematurely?
Woo!
She's like, no. And I'm like, if you don't get him to the medical doctor
Hmm.
to address underlying concerns, and blood pressure was high, glucometer, I think his fasting glucose was like in the 200s. And I said, I am just a dentist, but I'm telling you, all the signs here lead to a premature death.
Come
And so
on.
I know that in a lot of cases, it's the wife that will drive the husband to seek preventive and,
That's it.
and needed care.
That's it.
I brought her in the room. I said, 100%, when you leave here, I want you to get on the phone with the medical, with your doctor that you see, because you guys have the same insurance. I need you to make an appointment for him. And I mean, you're 100%. That's snoring. And sometimes in sedation, when moderate sedation, we want our patients on the verge of falling asleep, but they're technically awake.
Right.
Every now and then, especially if like you're working on the lower and you put a little
Yeah.
pressure,
Mm-hmm.
you'll hear that snoring noise.
Yes.
Typically, what I do, I just grab the back of the front teeth, go like that, and then you'll
That's
hear
it.
them go,
That's it. That's it.
right?
That's it.
But what happens is, and I want you to see if you agree with this. We're in a world where dentistry has to be done fast to be productive. The faster you go and the higher the risks are because you are providing sedation, does speed allow for safety? Or are we thinking of it in the sense of, or should we be thinking of it in the sense of, if you're going to do sedation, give yourself more time. Don't worry about the production, because obviously you're driving faster on a riskier road.
Mm.
Does that make sense? Like, how
It
should
does.
we be thinking about it?
And so I know what I should say. Let me I know what I should say, right? I know I should say that we need more time and so forth, and you're 100% correct. But don't forget too, most patients get sedation from dental because of the fact that they have anxiety.
Mhm.
They're afraid of the dentist. So if without sedation, that procedure would take a lot. So sedation in that case speeds up the process, right?
Mm.
Because once the patient is comfortable, you can actually do your work without fear of moving around, biting down, doing all these extra things that are going to cause more trauma or are actually more dangerous.
Mhm.
But you're right. There's a neurosurgeon that I know will schedule 30-minute extractions for all four wisdom teeth
Mm.
with sedation. And to me, that's crazy. Even if you're really fast, and he's incredibly fast at removing thirds. But that sedation part of it says to me, if you did an hour and let's just say it took you 50 minutes to do the extraction, cool. Now you have 45 minutes to do what? Get that patient comfortable, make sure that that patient is good before they get dismissed. That I know for sure, and I'm not going to say any names, but that doctor I know for sure is literally Chuck, suture, gone. Let me leave it up to my assistants to make sure that that patient is fine. That is not how it's supposed to be. So he's on the Autobahn
Right.
going 150, 300 kilometers for our foreign listeners. We're going almost 100, probably like 200 miles an hour.
Mhm.
Instead of saying, "Hey, this is my opportunity to coast a little bit." I did my extraction. I'm very talented in that, but now it's an opportunity for make sure that the patient's fine. And so he's basically walking a very tight rope. And
Mhm.
so I get what you want me to do, right? You want me to say, hey, you know what, slow it down and so forth. But I do believe that most of the time sedation is because of anxiety, which would then lead to, right, it actually being a lot faster if I'm sorry, without the anesthesia, it would be a lot slower of a procedure.
Right. Right.
Right. But with anesthesia,
Right.
then you have so much control. And as dentists, we're very much of a type A, everything needs to be under our control. So that allows you more time to do great work, proper work. But a lot of people don't think that way.
Right. Right. And I think where I was getting with that, I'm glad you said that because it makes me want to clarify it a little better. If let's say a certain procedure would take an hour and a half on a normal patient,
Hmm.
on an anxious patient, we might estimate might take 3 hours.
Right.
Right. What I'm seeing is with sedation, they're scheduling it for 1 hour.
Yes. Okay.
Right.
I see what
And
you're
so
saying.
it's like,
Yep.
because and this I had a patient that I was sedating for another provider, and I tried to prep that provider, and I told them the patient is still technically awake. You still have to be as gentle as you would be with a non-sedated patient. Patient high anxiety. I get her sedated. She's right where we want her. We titrate very carefully. He goes, okay, am I good to go? Yeah, you could tell he was anxious because I take a little while. I'm not going to rush sedating somebody. He goes in there with the anesthetic, slam, slam, slam. Patient is stimulated out of any sedative state. She's crying. And I'm looking at him like I literally want to jump the chair and just pile drive him. Because when I'm dealing with the patient, I take that patient's safety, comfort, experience very seriously.
Okay, real quick, before you continue the story, what is the one thing that, like you just said, what is the one thing that a lot of doctors think with sedation? They think that patients can't feel pain.
Yeah, yeah. Now, with general sedation, correct, right? Because there's no response to pain
That's why they're
stimulus.
breathing for you. Yes.
That's why they're breathing for you. With deep sedation, I mean, you give someone propofol and ketamine, they may not respond to pain stimulus. You still got to anesthetize, though, because the level of surgery can be, or the pain that you're still causing, right? With moderate sedation, they are technically awake, they are responsive, they have their respiratory drive, right, and their protective reflexes. And if you create pain, you can stimulate them out of that sedative state. All that to say, for anyone listening that doesn't understand moderate sedation, those drugs give you amnesia. So most patients think they were asleep,
That's
which
it.
is why we love it. It's so safe.
That's
And
it.
you come back like, wow, doc, I don't remember nothing.
Don't
I was
remember. And
out,
that's the key. They don't
right?
remember.
They don't remember nothing. But you still have to be gentle. You still have to take your time. You can't just go in there and just, put the knee to the chest and start yanking teeth out with and remember, moderate sedation, we're giving something like diazepam or midazolam, which are your benzodiazepine sedatives. We're also piggybacking that with fentanyl or hydromorphone
You
or
want to forget.
Paradine, some type of
Yep.
opioid medication.
Yep.
But we're giving you doses that are very low and very safe. But I fear that the faster you go, especially in a world now where you got such turnover of staff, if your staff has been with you 10 years and you do the same procedures day in, day out for 10 years, yeah, your speed will get faster because everybody is calibrated and trained to that specific job duty.
Thank you.
Nowadays, we don't really have that. It's really hard to find any dental office with, where most of the staff has been there over 10 years. And I just feel like we've got to slow down. And what I see from this case, mind you, again, I don't know, so it's all my own conjecture and presumption. What I see a lot of oral surgeons do and some general dentists, they just bolus general amounts. Okay, if most of my patients take at least 5 milligrams of midazolam to get me where I want them, instead of titrating it slowly, I'm just going to slam 5 in there. And for maybe 60, 70% of your patients, that might work. But this is what happens. And I want to share a study with you here. Let me get my screen up again. Tell me if you're able to see this here.
Yeah, I can see your screen. Yep.
Okay. So this is a study published in, I think this was 2017, in oral surgery, oral medicine, oral pathology, and oral radiology, looking at as a systematic review, looking at deaths in a dental setting all the way from 1960 to 2015. Now, it is rare, okay? It's not extremely common to have deaths in a dental setting. It's a very secure outpatient setting. But what they found is that the vast majority of these deaths were either related to anesthesia or airway, loss of airway.
And those were the two things we just talked about. We spent
And those are the two things we just talked about.
That's
and
it.
There is nothing more heartbreaking than reading some of these stories and reading the details of the story. And in your head as a provider, you're thinking, damn, I feel like I could have avoided that. I could have, if I could have just talked to the team and said, hey guys, when the patient is done with your wisdom tooth surgery, don't just put them in a generic room and leave them alone. Make sure someone is monitoring them until they're more awake from that propofol so they don't stop breathing. Make sure they're not, if you put gauze in the mouth, make sure there's floss tied to it so they don't accidentally swallow the gauze and constrict their airway. It's heartbreaking. It's 100% heartbreaking.
The funny thing is people will do the same thing. They'll leave patients even under nitrous.
Mm-hmm.
They'll just leave patients and walk out the room, and nitrous is still going on. I'm like, you cannot do that. And we may look at it and go, but that's not the case. That's not the case. It's not we're being extra. We are trying to make sure that we eliminate any headaches. And I'm not sure about you, but the older I get, the less headaches I want in my life.
Preach.
I used to be an idiot, and I wanted all the trouble.
Right.
I want problems always. I used to want to cowboy up and I want to try this and I want to try that. And the last time we went to a conference, we were talking about sedation. We were talking about all the procedures that we stopped doing as a collective group. And we were like, there's certain things we just don't want to do. Or if we're going to do it, that might be the only case. Like zygomatic implants, that might be the only case all day, because I'm like, I need as much time as possible. The more you do, and people think that specialists always just want to keep stuff to ourselves. We don't want that. We want simplicity. We don't like surprises. It's not my birthday, don't surprise me. You know what I mean? Like when it comes to anything, we don't want surprises. So we have no choice. There are certain things, I know you, LeRoy, that you'll do that other general dentists cannot do or will not do, right? But we have to take on that because no one else. It's like us and there's no one behind us, right? And so we have signed up to take on some of that extra cases or hard work or whatever it may be, right? That's why a general dentist can refer to a specialist. But we're also to a point where we're like, what can I prevent? The low-hanging fruit would be airway. Low-hanging fruit would be monitoring. Low-hanging fruit is titration. Like these are low-hanging fruits because there's so many other things that we have to worry about that why not at least ace the low-hanging fruit? And when you have corporate environments, when you have speed, when you have pressure to produce, those low-hanging fruits are kind of, I'm going to say ignored.
Yeah.
I'm sorry for the rant.
I know we're wrapping up here, But because I do a lot more traveling work now, 'cause when I had my offices, I controlled systems.
It's a pain in the ass, isn't it?
It is. It is. And what
Now you
I've
know why I
learned,
complain so much to you.
right. And what I've learned is I have to be very adamant with these offices. If we're doing something that I feel is higher risk, I need more time. I need to come in early, and I need to make sure that things, for example, you may have your emergency oxygen tank in the place you've had it in your office for the last 20 years. All your assistants are new. I don't know that they know where emergency stuff are at.
Hmm.
So what I'll do, like if I'm doing a sedation case, I'll have all the emergency equipment in the room.
Makes sense.
I have my sedation. I have a mobile cart where I have like my advanced airways and Yankauer suctions and all that stuff. I have it right there. I have it laid out. I pre-measure the patient's airway, so I have the correct LMA in case we ever need it. Everything is sitting there. But the office stuff, the emergency oxygen tank, the emergency drug kit, all that, I bring it to the room. Because I have my sedation emergency kit, but there's certain stuff like, I'm not required to have an EpiPen in my sedation emergency kit because every office already has one.
Should have it.
I happen to spend the extra $200, $300 just to have one because I'm like that. But what I would do prior to making that decision, I would make sure everything that I could possibly need is right there. Right? I would have a dedicated assistant that I've worked with and I've trained on how to monitor. But I have a huddle with both my assistants, my procedural assistant and my anesthesia assistant.
Mm-hmm.
And I tell them, I walk them through. This is what this is going to look like in the beginning. This is what I want you to look out for. If said things happens, you will grab this, right? You will call 911. Like I walk them through that appointment right before because the
And how
last
long
thing
does
I
that
need,
take? How long does that take?
it probably takes about 10 minutes, 10, 15 minutes of a pre-huddle. And my big thing is I've had emergencies happen in the dental setting after,
Yep.
almost 20 years of practice. What I learned is people freeze. And going back to the training scenarios, so I went out and I bought a CPR dummy that has the little light indicators for depth and rate.
Yeah,
I
when
got
you're
to
compressing.
practice AED. And when I owned my offices twice a year, we would run almost like ACLS
Yeah,
emergency scenarios. You would be amazed
that's
how many
advanced. That's
people,
advanced life support. Just
right,
so
advanced
ACLS.
cardiac life-saving support scenarios. So we would run through scenarios of everything from simple passing out or syncope to anaphylaxis to myocardial infarction or heart attack to stroke. And we would spend a half day just running scenarios because what happens is people freeze. You're like, hey, grab this. Adrenaline spikes. All they hear is their own heartbeat. I don't want my daughter, my wife, my mother being the patient and the team freezing that's working on her. And that's how I respect every one of my patients. Like I want my team being, NBA level responders, you know, elite level responders. And I just don't feel a lot of offices do that.
Well, it's funny because I know in medicine that they go over that they do that simulation, I think quarterly, if I'm not
Mm-hmm.
mistaken. They're very much on a regular. They do on a regular, hey, you are the person that does this, you are the person that does that. They have to do that. I'm not sure if it's by law or if this just to cover their own ass, but they have to do something like that, right? I wanted to ask you when it comes to you were talking about the emergency kit and so forth in the office. How many times have you actually asked anybody in that office, an assistant, hey, where's all your emergency stuff? Where's all your, first aid? And how many times have you been like, let me go ask?
Bro, it's scary.
Yes.
It's
Yes.
scary.
I mean, yes.
And that's part of my checklist whenever I go to a new office. I'm stable with my 3 offices that I'm at now, but while I was doing more or finding new offices, I had a checklist. And you'd be amazed how many staff, even managers, had no idea where to find the checklist. Where's your emergency drugs? Where's your emergency oxygen? Where, or sometimes they would have it, and when we'd find it, stuff would be expired. What about your spore testing for your sterilizers? I've been in so many offices where no one is sending the spore testing off. You're supposed to send weekly. Where's your log for shocking the water lines? In most states, you got to shock your water lines now. I almost don't want to ever get sick and go to the doctor or the dentist. you know,
You're like,
you know,
no. Take me 20 minutes away, please.
yeah,
But you're right. No, please, go a
yeah.
little further. I'm
Next
okay. I'll
hospital,
be fine.
next one.
I will survive.
Right. So, but
No,
listen, man,
it's
I think this was even though we're talking about a deep subject, and our hearts go out to the family of the person that passed away. I hope that anyone listening to this, the true takeaway is play it safe, drive slow, and truly treat every patient as an individual. Try to resist the external forces of having to produce, having to set these, and I get it. We got to keep the lights running, but not at the cost of patient safety. And you know what? This particular provider may have done this thousands of times in the
yes,
same exact way.
yes.
Most of our patients are not going to pass away, and we don't know what happened, but there's certain things that I feel I've seen enough from both specialists and general dental providers where I could say we could all benefit from setting our safety margins just a little bit safer, you know.
Yeah, and yeah, like I said, the low hanging fruit's one of those where we need to kind of say, okay, at least let's get that right, right? And another thing that I'm gonna say, speaking personally, is it's okay to say no.
Mm,
I feel like as specialists, we are so prone to just say yes because it seems like we're like the last line of defense in a way. So,
mhm,
and in a case like this, when you see obesity, morbid obesity, when you see hypertension, when you see all these things, you can say, you know what, I may not be the provider to do this for you because of, and it's not you because of your skill level. I can guarantee you that extraction was very simple, and that was the easiest part of the whole solution.
mhm,
But you may say, I don't have the facility to treat you properly, just in case something were to happen. And how many times have I said that? My God, so many times. I'm like, I am not the provider for you because I don't have the facility to help you if anything were to go wrong. And do you know how many times people have said, thank you for your honesty? Do you know anybody who can? And I'm like,
mhm,
sure. But I don't look at it as I'm losing out on this production. The office might, the office manager might, the regional manager might, corporate might, but I do not because I am going to be the one that would be on the line if anything were to happen because I know I mean, LeRoy, please tell me if I'm wrong, but it doesn't say LeRoy Horton and Co. and Company on your dental license,
mhm,
does it? It doesn't say and
mhm,
company associated with it. It doesn't say any. It doesn't say that. It just has your name on there. That's what
mhm.
I figured. And
Yeah,
so based on that, it's my ass.
yeah,
It's
yeah,
my ass that's on the line, not the company's, not the office manager, not the office. It's my ass. So I'm going to protect who? This guy.
absolutely,
Survival of the
absolutely.
fittest. So I really want people to really start thinking that way. If you don't feel like you can do something, not based on your skill level, but maybe just based on medication, facility, whatever it may be, we need to really start thinking that way. And I know that there's a lot of pressure, especially new grads. And we'll talk about that hopefully another time with new grads and the expectations that these new grads have. We were just looking at a mentee of ours and a contract that, she was putting out there and we were like, huh, how realistic is this? Right. And
Yeah.
so we'll talk about that later.
Well,
But
yeah,
yeah.
that'll be our next episode, man. Because I've got a couple mentees in that same boat where I'm looking at the contract like, wow, this is an amazing contract. So
Incredible.
amazing, I can't believe it's actually real. And then yeah, and we'll talk about the nuances of where it's actually not real, or in most
At
in
all.
most cases, it's not real.
At
But
all.
listen, bro, I appreciate you. It's always good to reconnect on a platform like this. So now I got an excuse to bring you back yet again out of retirement. Okay. Every time I talk to you, you're
Listen,
like, nah,
I
I
know
don't
I
wanna
appreciate it.
podcast no more, but the
Yeah.
world needs your voice, brother.
No, no, I
Seriously.
appreciate it, and I know my family does
Yeah.
because this is a time where they don't have to deal with me. So I know for sure that you might get a phone call talking about thank you. I appreciate it. He is able to get all that energy out. So man, appreciate you
Next
having
time,
me.
can you guys do a 2-for-1 episode? Can
Right.
you get 2 hours? Hey, we enjoyed that break.
You, you can do a 3 hour,
Right.
however long you need. Just please do it. Oh, I know, but nah, thank you, brother. I really appreciate it. And I love this podcast, man. I really do.
I
I
appreciate
really
that, man.
think it's needed. I really do. And,
Good.
and you're giving out free game where people have to pay to come to your courses. You're giving this out for free. So I don't
Absolutely.
understand why people don't see these kinds of, because there are a lot of, that I listen to, and I'm just like, you just told me everything that I could have read in 2 seconds. But here you are showing, showing studies and everything else. Same thing that you would have to pay for. You're giving out for free. So man, come on. If anything, I enjoy it. I'll speak for myself. I enjoy it. So I appreciate you providing the free podcast and the free ability to gain some knowledge, man. So I'm hoping people take advantage of it. But hey, I can't speak for everybody.
I appreciate that, man.
Come
So
on,
to all
man.
our listeners, we'll leave you with our parting words from Dr. Walter Ackah and myself. Keep reading, keep listening, keep learning, and we'll talk to you soon. All right, take care.